Gail said, the focus of our talk today is going to be depression. We'll get to that in a minute. But both Dr. Kim and I wanted to start by speaking a little bit to why this is our community and why this community matters to us. I was born and raised in the Chicago area, but my mom was a first-generation Korean immigrant. She grew up in Seoul. She moved to Baltimore when she was 16, and then came to Chicago later, which is where I came into the picture. And so the Korean community has always been my community. And more than that, my wife is also the daughter of two first-generation Korean immigrants. She was born in Flushing and grew up in Long Island. And my one-year-old son is also Korean. So this kind of work, this kind of community is really important to me because my family is part of the Korean community. And I think, especially in today's age, we want to be doing all we can to not just help people in general, but help the people who have helped us. And so for me, this is an opportunity to do that.
Hi, yeah, so just to introduce myself also and talk a little bit about my background. So I'm Dr. Katherine Kim, and I'm actually from New York. I grew up in Bayside, Queens. My parents are immigrants who came to the United States, are actually here. And, I'm very familiar with the Korean American community, what it's like to grow up in Queens. I went to Hunter College High School before going to undergrad. So I know how hard it can be to talk about these topics, how much stigma there really is. And I'm just really grateful to the Esther Ha Foundation for, this opportunity for us to talk about something, that we see all the time and is an incredibly treatable illness. So I really appreciate this opportunity.
And with that, we do want to acknowledge too, today's topic is depression. We're going to be talking about some pretty serious things, which include suicide. And so we like to give people a heads up that those are things we'll be discussing today. All right, so let's get started. So we thought before we start getting into more of the nitty-gritty information, we want to take a step back together and reflect on, how these issues come up, how it affects us each individually. And so I want you all to just imagine for a moment, a scenario like this. So, picture for a second that you have a cousin, say he lives in Long Island City, he works at an advertising agency in Manhattan, he works as an account manager, he's been in a relationship since his senior year at Baruch, he grew up in Flushing and regularly sees his parents there. And at a family event, you notice he looks different. He looks a little more tired, a little more thin than he usually does. And he actually tells you he's been having trouble getting things done at work. He's not enjoying seeing his friends as much as he normally does. And he asks if you think something is wrong with him. And so this is a fictional story, but a lot of these pieces may be things we recognize from our lives. So I want you to imagine that scenario for a second and think about what would you say to him? What would you say to a family member or a friend who approaches you, who confides in you something like this? And what do you think you could do to help? And more than that, what would you do yourself if you found yourself in a situation like this, as some of you may have? And so these are some of the questions which inform the work we do every day, but also inform what we're going to try and talk about today. And one last acknowledgement we thought was really important today too was, we're having this opportunity to connect, to come together as a community today, which I think is a special thing. But I think it's also important to acknowledge that we've been in a pretty challenging time. The past more than a year now has been really stressful for everyone across the world, across the country, certainly across this city. But in particular, Queens is perhaps hit hardest in New York City, which is perhaps hit hardest of anywhere in the country. And then on top of that, in addition to this pandemic, we've had to deal with the rise in Asian American directed violence, both here in New York as well as other places like San Francisco, and of course the tragedy in Atlanta. And so this only adds to the stress and fear we've had to manage. And these are all part of the picture. So, stress, isolation, medical illness, all these things can contribute to depression, and we'll certainly address that. But we both want to acknowledge that these are things we've been collectively experiencing, individually experiencing. These are things that are especially affecting the community we're a part of. And so I'm grateful that we have this opportunity, even if it's digital, to be a little less alone and to talk about some of these things.
So here are the objectives for our talk today. By the end of this talk, we hope that you'll be able to recognize the signs and symptoms of depression and know what we mean when we give a person a diagnosis of depression. We also hope that you'll know a little bit more about the causes and the science behind depression. You should learn by the end of this talk which treatments for depression are available and understand how and where to get help for yourself or a loved one. We hope also to have some time at the end to answer your questions, including those that were submitted before the talk.
All right, so big picture, what is depression, right? This can be a confusing question, so we should start here. And so this is tricky because in the English language, we often use depression or being depressed as an equivalent for sadness. Sadness being obviously like a normal part of the human experience, a very common, if unpleasant emotion we all have to deal with. And this cartoon is making a little light of it, but I think it captures this difference that, again, sadness, you can feel sad if you fail a test, if you don't get a promotion, if you have a bad day at work, if you get in a fight. That's one thing. That's a specific emotion we feel at a certain time. Depression, when we're talking about it today, this is a clinical term. When we speak about it as mental health providers, this is something which is the result of specific diagnosis, specific criteria, and it's a disorder. What that means is it is a specific thing that's been recognized by lots of years of thought and research and clinical work, and it's also a treatable thing, but it is different than normal sadness. So what do we mean when we talk about clinical depression? So Dr. Kim and I are both psychiatrists. This definition comes from what's called the Diagnostic and Statistical Manual, which is a very large, very detailed document that the top psychiatric minds in the country get together every 10 to 15 years, and they reflect on the current research, they reflect on the current clinical practice in the field, and they agree on these really specific and rigorous criteria for how we categorize and diagnose mental illness. For depression, there's really specific things we look for. So in addition to depressed mood, in addition to having those sad feelings, we're looking for at least 5 of these other things for at least 2 weeks long. So these other symptoms can include loss of interest in activities, taking less enjoyment in things we normally do. It can result in changes in appetite, either increased or decreased, increases or decreases in weight. Similarly, changing in sleep, sleeping more or sleeping less, feeling restless or slowed down, having less energy, feelings of guilt or worthlessness, difficulty concentrating or getting things done, and lastly and importantly, thoughts of suicide. And so if you're experiencing, again, both this feeling of feeling down or sad and at least 5 of these criteria most days for 2 weeks, you have what we would call a case of depression, a major depressive episode. And so with that, again, what I want to underscore here is that this is something, our goal here is not for that each of you should be able to leave this talk and be diagnosing yourself, diagnosing your friends, diagnosing your family. That's a more nuanced thing that we as professionals, it takes us 30 minutes, 45 minutes, maybe multiple exams to come to that conclusion. But it's to provide both a framework for understanding that there is this clinical aspect to it and that this is a thing that we can recognize and we can treat. And so if you're starting to notice that these things are popping up, that may be a clue that you or someone else needs to get help. And with that, it's also important to acknowledge, who does get depressed? And the answer is essentially anyone. And I think something I've heard at times is, oh, you're too young to be depressed, or Korean people don't get depressed, or when I was growing up, people didn't get depressed. I'll go into more statistics later, but the fact is, young people can get depressed, middle-aged people can get depressed, older people can get depressed. And with that, I was talking about these diagnostic criteria, but these are usually characterized as specific episodes, so they don't last forever. but they do tend to last longer if they're untreated, and they tend to be harder to treat the longer you go without getting help. So we want you to bear that in mind as well. All right. So is depression a problem? What's the scale of this problem? And unfortunately, as Mr. Ha was saying, this is a big problem. It's estimated, across cities, cultures, countries, about 10 to 20% of people in the population are going to be clinically depressed at some time during their life, and that number is going up. The average age for a first depressive episode in the United States is about 30 years old. And importantly, only about 65% of adults and 40% of teens in the US who have clinical depression got treatment for it in 2017. And so that's part of why we're here today, is because this is an undertreated problem, and it is treatable. The World Health Organization estimates that it's the fourth leading cause of disability worldwide. It's thought that it costs the US economy about more than $200 billion a year. And suicide was the 10th leading cause of death in the United States in 2019. So depression is a problem. It's a very real problem. It's a pretty big problem. Now, we do want to take a minute to address the question of suicide. Obviously, this is a complex topic that could be many talks unto itself. But it's important to note, it is one of the, having thoughts of suicide is part of the picture for potentially having depression. But also to clarify, not all depressed people are suicidal, and not all suicidal people are depressed. That being said, suicide is essentially viewed as the worst outcome we can have in our field of mental health, and it's a serious problem. So, 5% of American adults are thought to have had serious suicidal thoughts in 2019. In that same year, almost 1.5 million adults attempted suicide, and more than 44,000 Americans died from suicide in 2020. And this is something which isn't just a problem in the US, it's also a very big problem in Korea, where it's gotten quite a bit of attention. It's currently the leading cause of death for people in their teens, in their 20s, and their 30s in Korea. And celebrity deaths by suicide have brought a lot of attention to this issue, both here in the US and in Korea. And so, again, it's a difficult topic, it's a complicated topic, but it's part of the picture when we talk about depression, and specifically, as we'll go into more with getting help and and where you can go for that, active suicidality. So having not just like, I don't want to be here, but thinking I'm going to kill myself, having an intent like that is considered an emergency, a medical emergency. And it's something which should be treated as such by getting someone to a hospital and to medical providers as soon as possible.
So now that we know a little bit about what depression is and what it means for someone to be diagnosed with a major depressive disorder, let's talk about how we understand what causes depression in people. So in psychiatry, there isn't one way to answer this question because it's a complicated question with many different variables. But one way we understand how people develop mental illness in psychiatry is with something called the diathesis stress model. So diathesis means a predisposition toward a particular state. So in this case, when we're talking about someone's diathesis, we're talking about their baseline vulnerability or predisposition to becoming depressed in their lifetime. Someone's diathesis can be influenced by many different factors, including, as I list here, biological ones. So genetics, family history, medical illnesses, others, as well as childhood experiences, including experiencing trauma, neglect, or abuse during development. So when there's a stressful life event, someone's ability to cope with this stress is affected by their diathesis. So if you look at these two cups on the bottom right, and the diathesis is the blue liquid, person A on the left has a lower diathesis for depression compared to person B, who may have both biological and childhood risk factors that increase his diathesis for depression. And when confronted with this stress, which is the pink liquid, unlike person A, who's able to hold the stress and deal with the experience without becoming depressed, person B has his cup overflowing and is unable to cope with the stress and will possibly develop a major depressive disorder. Next slide. I wanted to emphasize here that someone's diathesis for depression comes from a combination of risk factors and life stress and is not a sign of weakness in the person. It's not a moral failing, not a choice that someone's making. And as Dr. Whitney talked about, it can be differentiated from normal everyday sadness. It's a clinical condition separate from sadness. Next slide. And as I note here, the stress can be known or unknown, in that sometimes it isn't always obvious what the cause or the trigger for someone's depression is, and why it's so important to seek treatment from a professional when you notice the signs of depression in yourself or someone you love. Next slide. I bring this up because, as we all know, there is enormous stigma in the Korean and Korean American community against mental illnesses like depression. Stigma is defined by a negative social attitude about a characteristic of an individual that may be regarded as shameful. And the social attitude leads to discrimination and exclusion of that individual and prevents people who really need help from asking for it. We know that in South Korea, only about 7% of those affected by mental illness actually seek psychiatric help, despite the fact that South Korea has one of the highest suicide rates in the world. And as we know from the suicides that we see in the news, as Dr. Whitney pointed out, and these are just a few of the dozens over the past few years, anyone can have a mental illness, whether they're comedians, athletes, politicians, singers, actors. They can be extremely famous and successful like these people were, or just normal people like you and me, any age, men or women. The thing that most of them, though, have in common is that they're usually suffering alone, not realizing that mental illness is a medical condition that has been studied and is treatable. And it's why attending talks like this one is so important for helping to educate others and reduce stigma in our community. Next slide. And just to emphasize the point that we see mental illness as a biological disease of the brain, we do know from decades of research that depressed people literally have changes in their brain structure, including changes in some of these brain regions here shown on the left. And just one example is the hippocampus, which has an important role for learning and memory. And this actually is found to be smaller in those with major depressive disorder. And with treatment, this brain region does normalize. We also know that people with major depressive disorder process information differently, favoring negative over positive stimuli, such that it's harder for them to be optimistic and hopeful for the future. And then on the right, we can see that there's a role of the inflammatory factors that affect various brain regions and lead to changes in the reward circuitry in the brain and other circuits in the brain that make depression possible. Next slide. So now that we know a little bit more about what can cause depression and how it affects your brain, we can talk about what it is we do to treat the depression. It's a biological illness, so we have biological methods of treating it. And the two main treatments for depression are medications and therapy. And I wanted to emphasize that although either can be used effectively in the treatment of depression, studies have shown that it's the combination of medications and therapy that has the best chance of success. So before talking about specific medications, we can talk about some myths about taking medications for mental illness. Next slide. The first myth that I wanted to address is that antidepressants are happy pills. This is not true. Antidepressants are not just happy pills. They can't cause you to feel euphoric or high and are not addictive like street drugs like cocaine or heroin might be. Antidepressants work by correcting a problem in the brain, as we saw in the earlier slide, And this problem in the brain stops someone from being able to be their normal self and feel their best. Taking an antidepressant is no different from taking something to regulate one's blood sugar if someone has diabetes, or to lower someone's blood pressure if they have hypertension. And you're just simply helping the body return to its normal functioning, which includes the ability to feel the range of human emotions, including happiness, including sadness. Next slide. Yeah, so medication myth number 2, taking an antidepressant will change my personality. This is also not true. Antidepressants don't have the ability to change someone's personality. And when I actually talk to patients who've taken antidepressants, they actually say that they feel like they're back to their true personality and can finally remember who they were before they were depressed. So actually, depression can mask someone's personality. And by treating the depression with antidepressants, people often feel that their personality is back. And lastly, medication myth number 3, if you start taking an antidepressant, you'll have to take it forever. So this is not necessarily true. Once someone starts taking an antidepressant, they're not chained or trapped to having to take the medication forever. It is true that for some people, especially those who've had multiple depressive episodes or a very severe long depression that's been hard to treat, they often do better with lifelong treatment to both treat and prevent future episodes. But for someone with a history of maybe 1 or 2 mild depressive episodes, it's sometimes not necessary. And it's important to always talk to whoever is prescribing the medication about your options in order to make an informed decision about the length of treatment. So going on to treatments for depression, there are many different types of antidepressants that might be started, as you see here. And there are many more that aren't listed. We're lucky in psychiatry that we have a lot of different options for treating depression. And one of the most common type of medication that's started, because people tend not to have too many side effects on it, are the selective serotonin reuptake inhibitors, or SSRIs. So SSRIs work by increasing the levels of serotonin in your brain. Serotonin is an important neurochemical that helps regulate mood. And this increase in serotonin causes other downstream effects in the brain structure, including promoting brain growth, and over time helps normalize mood and treats depression. The other medications work similarly, but possibly on different neurochemical structures, but all generally work equally well, and any of them might work well for an individual person. So here's just a list of some things you might want to know about treatment with antidepressants. First, using antidepressants to treat depression is actually a very straightforward thing. Dr. Whitney and I do it all the time. And it might not necessarily even be a psychiatrist who needs to prescribe the antidepressant. It could be a primary care physician or a psychiatric nurse practitioner who does the prescription. The other things that are important to know, and this might seem obvious to some people, but the antidepressant medication needs to be taken as prescribed, usually once or twice a day, depending on the medication. It can't just be taken as needed on days someone's feeling depressed, because the way the medication works is that it builds up in your bloodstream over time and creates changes in the brain over weeks. It's not something where you feel the effects right away. Oftentimes, the prescriber will start at a lower dose and increase the dose gradually until it's at a therapeutic dose. This is normal and has to do with monitoring for side effects, monitoring for effects of the medication. And it's also important to know that although someone might feel a little better, start to feel a little better in the first 1 to 2 weeks of starting an antidepressant, studies show that it can take up to 6 to 8 weeks for the full effect of a medication to kick in. So it's okay if someone doesn't start feeling better right away. Generally, patience is key in treating depression. And in the meantime, the prescriber working with that person will work to increase the dose to a therapeutic level. Someone might need to try several different medications to find one that works for them. But as I mentioned, there are a lot of options to try. And importantly, it's important to know that even if someone is feeling better, to not stop taking the antidepressant without guidance. As I mentioned earlier, a decision about the length of treatment will depend on how severe the depression is. But generally, we still recommend that someone stays on the medication for at least 6 months after they're no longer depressed in order to prevent relapse. And this is just to highlight the point that it's important at all times for patients to be open and communicate with their prescriber about their symptoms, the medications, and the length of treatment.
All right, so thank you, Dr. Kim, for talking about medications. We're now going to talk about the other part of treatment, which is also important, which is therapy. So when it comes to therapy, a few takeaways. For one thing, it works. There have been a lot of studies on this, and a very large research review found that almost twice as many people with depression went into remission when treated with therapy than not being treated. And to again emphasize, what's considered sort of the gold standard for treatment of depression is the combination of both psychotherapy and medication. And this has been reproduced many times in the science that folks who are getting both do better than the folks who are getting nothing. They do better than the folks who are just doing therapy. They do better than the folks who are just doing meds. So in most cases, we'd recommend both if it's possible. Something that can be quite confusing in the mental health field is there's a lot of people with a lot of different titles wearing a lot of different hats. Any psychiatrist has been called a psychologist a million times and vice versa. So just a little clarification, this is a very general overview. But when we're talking about treatment, the specific people who usually are in charge of prescribing the medications, probably the most specialized folks are folks like Dr. Kim and myself, who are psychiatrists, for folks who went to medical school, and then we've done additional extra specific training in mental health. That would be a psychiatrist. That being said, many people, especially for things like depression, they do get their prescriptions written by a primary care doctor. So your internist, your family medicine doctor, the person you see who checks your blood pressure. Many of those providers are very skilled and comfortable with managing depression and can prescribe the same medications we would use. And the good thing is they're largely safe. And so this is a way a lot of people get very good help. In addition to that, there are what sometimes are called mid-level providers or advanced training providers, where nurses who have done additional clinical training and who've gotten privileges to prescribe medications, called nurse practitioners, can also prescribe medications, and then also physician's assistant, which is a similar position. On the therapy side, this is also quite variable. Psychiatrists do therapy, especially where we live in New York. It's very common for psychiatrists to do therapy. Clinical psychologists are also folks with doctorate level training who specialize specifically in treating mental health. They have a lot of very extensive training in therapy specifically. There's other folks who also provide therapy. So there's licensed counselors, which is usually at least a master's degree, as well as clinical social workers who also perform therapy. And so these are all potentially great ways to get treatment. All right, so bigger question, what is therapy? So I'll just leave that hanging there for a second. I want you to picture what you imagine therapy to look like, because it can look like a lot of different things to a lot of different people. But what we often think about is the New Yorker cartoon, right? Like people, this image has very much been buried into the culture that it means, you know, lying on a couch, maybe with someone who doesn't talk very much, but it doesn't have to be that way. So in a similar way that Dr. Kim addressed a lot of myths around psychiatric medications, we're going to do the same thing for therapy here. So therapy myth number one, and this is related to stigma, this is related to how mental health is portrayed in our culture, but a big myth is that therapy is just for weak people, it's for crazy people, and this is not true. For what it's worth, almost all psychiatrists have engaged in therapy at some point in their lives, receiving it. We think if we're going to give it, we should be able to have examined ourselves as well. I think that goes for most mental health providers. It's something that can help people when you're not doing so well. It can be helpful when you are doing well as a means to avoid future episodes. And so it is not something which is just for the weak. It is not just for crazy people. It's in a way, it's for everyone. It's something that can be really beneficial across a lot of different circumstances, and particularly in the circumstance we're talking about, which is in the case of depression. Another myth we hear oftentimes: therapy is for people who just want to complain. And therapy can seem like this very mysterious thing. It's a very private relationship by design. Therapists usually don't talk too much about what they do, legally and professionally speaking. And people who are in therapy, because of stigma, because of oftentimes the sensitive nature of what's being discussed, people don't necessarily talk about what they do in therapy, what they experience in therapy. But certainly it is not just about complaining. In reviewing all those different providers and all the extensive training they undergo, therapy is something which a lot of very smart people have put a lot of work into thinking about and studying over many years. And with that comes a lot of different ways of doing it. And it's certainly deliberate. It's done in a professional way. And there are greater things at work than just, venting or complaining. I think in particular, one way to think about what a therapy relationship can offer is that most of us have friends and family, people we can go to when we do want to complain, when we want to vent. But inevitably, those people are also part of our lives. They're very much wrapped up in maybe what we're complaining about or what we're stressed by. And a therapy relationship it's a pretty special thing in that it can be an intimate and meaningful relationship, but it's one with very specific roles and very specific boundaries that the therapist is a professional who is there to both empathize and connect and relate to you, but also offer very specific skilled guidance in examining and managing whatever feelings and situations are being discussed. All right, myth number 3, it means talking about my mom. So this is another thing that's not true. That has definitely been reinforced in popular culture. For historians, Sigmund Freud does still hang very large over our field. There was a lot of very serious contributions made by him and his followers, which a lot of those techniques and thoughts are still relevant and used today. But this idea that therapy is just about, pouring over your childhood experiences or laying blame at the hands of your mom, your dad, your grandmother, whoever it was, this is not the case. And this is not the way modern therapy is carried out. What may be still relevant is, in some cases, it is helpful to look at child experiences and relationships, because those are often very pivotal to how we experience the world. But I think you'd be hard pressed to find a therapist whose primary interest is talking about your mother or any parent. And lastly, again, which was sort of represented in that first cartoon, there is this conception that it has to be you're lying on a couch. It's with a man in a suit who's jotting on a notepad. His office is this very esteemed library on Central Park West, and it costs $500 an hour. Now, there are people like that. You can do that. But I'm saying this is a myth because the vast majority of psychiatrists, psychologists, providers do not conform to this stereotype. And while mental health still can be very difficult, I want to acknowledge that it can be difficult to find a good mental health provider. It can be a daunting system to navigate. Part of why we're here today is because we want to dispel this myth that regular people can't get affordable, good mental health care. So it is possible to get affordable mental health care in New York City. And it can look like a lot of different things. So therapy, it can be, we're talking mostly today about individual therapy, but there's group therapy, which I know some of our attendees practice here. It can look like a lot of different things too. Some people are looking for more of this introspective, free-form examination of themselves and their experiences, and there's therapists who specialize in that kind of work. There's a lot of other therapists who specialize in much more specific skill-based work to address very specific goals about how we experience our feelings and how they affect our behaviors. And that can look very different than what maybe people preconceive therapy to be. It can also happen in all different types of places. So it's happening right now on the NYU campus in the Undergrad Health Center, where Dr. Kim and I have both worked. It happens in community health clinics across the city. It happens in hospital-based clinics like the ones Dr. Kim and I work in primarily. And it happens with private providers. And if anything, one of the great benefits of this unprecedented year is it's really opened up the possibilities for doing therapy in other ways. so for over the past year, I've done a lot of Zoom therapy. I've done a lot of phone therapy. And so there's ways to get help, even if there are barriers to getting it at times. All right, and separate from therapy, we want to acknowledge that beyond what we're talking about as treatment, where we're saying the gold standard is medications and therapy together for depression, we want to acknowledge that there's other things too in this mix. So when I'm talking to my patients, I often say that part of my job is to provide the expertise about giving medications, and that's good medicine. Part of my job is providing therapy, that's good medicine. But to me, what's also good medicine is healthy sleep habits. Sleeping well is good medicine. Eating a healthy, regular diet, that's good medicine. The practices that help you stay feeling well-adjusted, connected, happy, these are all parts of to me, good medicine. So if that's meditation, great. If it's attending church, great. If it's lunch and dinner with your friends twice a week, that's all relevant and important. Exercise, all of these things. I think especially this past year, we've all learned to appreciate when we can't do those things, the impact it can have on us. And so it's important to acknowledge that when we're talking about acute depression, yes, we absolutely mean that we should treat it with medications and therapy, but that both in the treatment of depression and in avoiding depression, all the healthy habits we know are good for us are still very relevant and important.
Thanks, Dr. Whitney. So now that we've talked about the treatments for depression, we wanted to also talk about what to do when you see a friend or family member who's dealing with depression. And before we do that, I think it's important to remind ourselves of what it might feel like to be depressed from the perspective of the person who's suffering. So here's a quote by William Styron in his book, Darkness Visible. I felt a kind of numbness and enervation, but more particularly an odd fragility, as if my body had actually become frail, hypersensitive, and somehow disjointed and clumsy, lacking normal coordination. So the writer here is describing how many of our patients feel when they're going through depression. And you can imagine how hard it might be for them to interact with others and function in regular society, feeling this way, numb, fragile, hypersensitive. And this person might have a hard time reaching out for help. So it's important to be able to help your loved ones recognize that they have an illness that can be treated and help them get the help they need. So let's say you do know someone who looks like they're dealing with depression, like in the scenario that Dr. Whitney started this talk with. What do you do? It can be scary not to know how to talk to someone about this. We talked about stigma. So that person might feel really ashamed for not being able to function as well as they normally do. And maybe don't want other people to know how much they're suffering. So here are just some tips for dealing with depression in a loved one. And this is from an organization called Mental Health First Aid, which is a group that trains people to handle mental health emergencies. So first, as we know, and we talked about, the most tragic consequence of untreated depression is suicide. If someone is going through a mental health crisis, it's incredibly important to look out for signs of suicidal thoughts or behaviors. And this might go from the person saying that they feel like the world would be better off if they were dead, or that life isn't worth living, to as serious as having a specific plan on how they might kill themselves, researching various methods of suicide, or writing a suicide note. And if someone is acutely suicidal, as Dr. Whitney mentioned, and you're worried that they're going to do something to hurt themselves, it's really important to encourage them to come to the emergency room, maybe even physically bring them there if you have to, or call 911 to keep this person safe. As we talked about earlier, and honestly can't emphasize enough, acute suicidality is a medical emergency, and it should be a psychiatrist who is a doctor who should be the one to evaluate and determine if there needs to be a higher level of treatment, like a psychiatric hospitalization. So secondly, listen non-judgmentally. It might seem simple, but people with depression are prone to feeling ashamed about how they're doing, and it's important not to blame them for how they're feeling. Listening non-judgmentally is important in helping that person feel respected, accepted, and understood, and more importantly, helps them see and makes it more likely that they'll seek treatment. In numbers 3 and 4, give reassurance and information and encourage appropriate professional help. Now that you're listening to our talk, you're all experts and know that depression is a real and treatable medical illness for which there are many effective treatments, and that people can get better if they get the help they need. So it's important for you to inform others that it's okay to be going through this, and that there are professionals like Dr. Whitney and I who are trained to help in these conditions. It's literally our jobs. And lastly, encourage self-help and other support strategies. As Dr. Whitney mentioned, in addition to medications and therapy, self-care is a critical part of maintaining mental wellness, and encouraging someone to take care of themselves by exercising, relaxing, meditating, feeling connected with friends and family, maybe take the day off if they need it, all will help that person get through this mental health crisis. And people who are depressed need that help, need the help of their loved ones more than ever.
Okay, and so in addition to those tips, we wanted to give some concrete resources. Many of these, we want to give credit to the great work that the Esther Ha Foundation is doing, and the resources they also have on their website. So one of the, especially in these emergent situations, emergencies don't always happen during business hours, right? So having hotlines and phone resources are often things we make sure all of our patients have. If you're watching now, you can even put this into your phone as we're talking. I have all of these in my phone. The Esther Ha Foundation has their own helpline specific for the Korean community. It's a 1-800 number. They have very extensive hours when it operates. I believe it's 10 a.m. to midnight. And in addition, if they're not open or if they're not reachable, the National Suicide Prevention Hotline, it's available 24/7, 365 days a year. It's a very professionally staffed, wonderful resource. And so that can be both for managing acute crisis as well as finding additional resources. We're also lucky that here in New York City, we are in a place which does prioritize resources for mental health. We have a service called NYC Well. They have their own hotline, which is available 24/7. In addition to the hotline, they also can communicate with people via text. So if you text well to 65173, you can talk to someone that way. They also have a website with an active chat feature, and so you can also connect with someone that way. So they have a lot of options for connection if someone doesn't feel like the phone is feasible. And then lastly, again, we're underscoring this because it is so important. In a true emergency, if this feels beyond your capability of managing either for yourself or for a loved one, 911. That's the way you can get additional help, and then they can get brought to a place where there'll be a mental health professional that's trained to deal and manage these situations to help you or whoever needs help. In addition, as I mentioned, the Esther Ha Foundation has a great directory of Korean-friendly providers. This is just a small sampling that I pulled from the website. There are more on there. When I was talking about treatment, right, it can be a lot of different places. So we have here some clinics. So the Hamilton Madison House is a wonderful nonprofit organization. They have a Korean clinic in Jackson Heights. Both Flushing Hospital and Elmhurst Hospital, yes, they're full hospitals, but they also have their outpatient treatment facilities for mental health where there are Korean providers. For adolescents or kids, there's the Child Center of New York has an Asian Specialty Center in Flushing. And then we also listed a few private providers. So these are our Korean folks, both Dr. Kim and Dr. Shin, who are on, their information is there, as well as on the Esther Ha Foundation website.